Good morning. So short safety statement at the start. This is an educational video. The information contained is not intended nor implied to be a substitute for professional medical advice, diagnosis or treatment. All content, including text, graphics, images and information in this video is for general information purposes only and does not replace a consultation with your own doctor/healthcare professional. If you're at immediate risk of harm, please call 999 or go to your nearest A&E department. And that's the end of the safety statement.
Okay, my name's Fiona Naylor and I'm interviewing Dr. Andrew Perry. So Andrew, who are you and what do you do?
Oh goodness me, that's they're already big questions, aren't they? Who am I? I suppose I'm Andrew Perry. I'm a clinical psychologist. I qualified in 2007. What do I do? I work in private practice. The area of clinical psychology I specialize in is in psychological therapy. I do that either online, like we're doing today, or I do that outside as a walk and talk, where I live in Stirling. I also run a online therapeutic group once a week, and I also have students. That's probably about it, isn't it? I have students. I don't do research at the moment, but I do write about psychological therapy as well.
Okay, and so do you have a blog or a website?
So yeah, I suppose that's the other thing I didn't mention, isn't it? I have a blog and a website that has free resources on it. For me, part of being a clinical psychologist is what's used to be called giving psychology away, so that we use the money that's been invested in our education and the experience in order to benefit people who don't necessarily give us money directly, and that we have an influence that goes beyond just people that I work with on a one-to-one or who come to the group.
Yeah, and I understand that the group is a donation model.
That's right. So that's once a week for an hour. There's a maximum number of 8 participants. The group has a long history. I won't tell you all about it now, but it's a conversation group, so it's not it's structured by the people who go. We decide what we talk about and to some degree how we talk about it each week. The idea is to be therapeutic for the participants. I encourage people to ask for help, and I encourage the group to help the people who ask for help. And yeah, it works very well in my experience.
Just to say that I attend the group and I also see Andrew on a one-to-one basis, and I've been seeing you for 4 years now. And am I right that you offer a free consultation just to see whether you're the right?
That's right. I always say to people, if a therapist or psychologist won't offer you a free consultation, then I wouldn't go and see them. That's my personal preference. If someone gave you an hour of their time to see whether you would be a good fit for each other, whether you would find the person okay to work with, then there's something, to my mind, to my professional opinion, there's something missing there in terms of how serious it is a decision to go into therapy with someone, to work with someone in a very personal and private setting. So it's really out of respect for the seriousness of the decision. And so some people come and just come for one, and that's fine. And some people keep coming, and that's also fine. And it's the arbiter of that is the client. This is the joy of private practice, is that the person receiving the service decides whether they want it and whether they want any more of it.
Which is quite different from the NHS model.
Yes.
So I know that when I first contacted you, I was in a bit of a crisis because my father had just died, and it was COVID, and I also have bipolar, and it was all getting a bit too much. And so, needless to say, I contacted you whilst I was in a crisis. And I'm just wondering that, in my experience, that few people sit down and plan their life and go, okay, in November, I'm going to try and find a therapist online to talk about all the things that I need to talk about. And so I'm imagining that quite a lot of initial calls are people who are finding things really tough at that moment in time.
Yes, I almost have a tagline when people contact me. They'll contact me on the website, or they'll give me a ring or leave a voice message. The tagline I put in my every email is, "Dear whoever the person is, thank you for making contact." And then I normally say, "I'm sorry things are difficult, sound difficult at the moment." And that's for two reasons. One, they normally give me a description of a difficult situation that they are in, and well, it's at the moment. It's a recognition that difficult situations come and go. But yes, you're exactly right. Most people come when things are very difficult. It's not the ideal time to come, I would say, in that different work is possible when we are mentally healthy, when we're calm, when we're stable, when our ducks are in a row. We can have just additional things are possible. So it's people will say, "Well, I feel fine now, I can stop," and that's fine. Of course you can stop, but you can also get something different and something additional when we're not in crisis that you can't get in crisis. So it's they're different and related things: a crisis intervention and a non-crisis intervention.
Right.
Does that make sense?
Yes, it does. And so in terms of, because you practice in the UK, but you also see people from overseas as well via online stuff. So in terms of your professional registration, who are you registered with? Who's your regulatory?
So there's two regulatory bodies. One's a government regulatory body, which is the HCPC, which is the Health and Care Professions Council, and the second one is the British Psychological Society. You don't have to be a member of the latter. You do have to be a member of the former to use the term clinical psychologist. It's the insurance covers me to work worldwide. I don't know how it works. I'm not an insurer, but they say I am covered to work with people across the world. So yes, that's the case.
Right. Okay. So, and what sort of settings have you worked in previous to doing private clinical work?
So I remember it's people because I've been doing this a long time. I've been asked that question lots of times, and I remember saying to people, "Well, I started off in a psychiatric hospital as a patient in 1997, which is virtually the start of my psychiatric career." Yes, I was in the Roundhay wing of St James's Hospital in Leeds for 12 weeks in 1997. And as a patient, and then over time I recovered, and then I started as a mental health advocate in 1998, and that was in Linfield Mountain Hospital in Bradford, and I was the first paid mental health advocate in Bradford. Is that right? No, the first paid mental health advocate in Linfield Mountain Hospital, which is the psychiatric hospital in Bradford. Then where did I work? That's a good question. I then worked. Where did I work after that? Then I must have started in Leicester to train as a clinical psychologist, and then worked in all kinds of different services in and around Leicester and Derbyshire and Nottingham. Moved on to forensic work, worked in St Andrews Healthcare, and that was in low medium secure, and then worked in community mental health teams, and then worked in Carstairs, which is high secure psychiatric care, and then worked in Bathgate, which was a community project on addictions, and then finally private practice, and that was 4 years ago. So the start of the lockdown, just before the lockdown, starting in private practice.
So that's a very wide spectrum of client groups and also models of working.
Yeah, I was 19 years in psychiatric hospitals in total as a working in psychiatric hospitals. So there's a lot of the advantage of all of that. I was talking to someone yesterday. It was you don't panic because there are disadvantages of the experience, but the advantage of experience is when you hear quite unusual or shocking or difficult or frightening or disturbing things. I'm not particularly shocked or surprised, and there's a nice way to put it. Extraordinary problems are ordinary to me in my clinical work. So I've worked at, I suppose from very mild to very extreme and very long-term mental health problems.
Right, okay. And can you explain again your connection with the university?
Which one?
Well, the one that you're connected with.
Or the one I'm connected with now. So I provide a work placement for 3 students for Stirling University. They are, what are they? They're undergraduate psychology students. They are, yeah, and they work with, they do something called participant observation. So they will not sit in with, they will participate in individual sessions with me, and they also do some writing for me and creating content for the website.
Right, and the details of the website and the blog will be in the description of this video. So now I can only talk about my experience, but like I said, I was in a little bit of a crisis, understatement, when I contacted you, and I know especially around the Christmas time, I was very suicidal, and the thing that really impressed me about you is, like you just said, you didn't panic. And one of the things that I found previously is that if I contacted a crisis team or a home treatment team and said that I was feeling suicidal, it would just snowball into something that I felt I had no control over, and people were making judgments about me based on little information, etc., etc. So from my point of view, it was really useful to have a professional who didn't push the red button and, you know, do all that sort of stuff.
Yeah, yeah. Well, thank you for the compliment, first of all. But it kind of comes back to, and I think that culture hopefully is slowly changing in mental health services and in wider society, that it's actually safer to discuss these things than to not discuss them. So you ringing me up and saying you're suicidal, to me, good. You've rung me up and you've told me. That is an indicator. If you look at the research, it's an indicator of you being less likely to do it than if you don't ring me up and don't tell me. So that, and it's almost turning round, I don't know, it's turning around the telescope and going, hang on, all right, we've got somebody who has identified something is problematic and they're seeking help. And that's a really good thing. And how then do we build on that in additional places for them to discuss? The whole premise of psychology, of psychological therapy, is that talking about things is most of the time helpful. Yeah, and that's something, I mean, you see in posters from Samaritans and people like that actually, yes, it's good. If someone tells you they're suicidal, it's not good they're suicidal, but it's very good they've told you. And if you can have a conversation about that and what that's like to be suicidal, what that experience is like, that it's nothing to be ashamed of, that it's nothing to panic about, but to take seriously, but not to panic about, to think about, what would the word be? I suppose be curious about, to consider. And there's, I'll just expand a little bit. There was a lovely video about the Falklands War, and this guy had come back and he'd got PTSD from the Falklands War. So that was on one of your questions as well. And he said, I keep a rope in the garage. And he said, I know what I'd do it. And he said, but it's a safety net. And it's like, okay, right, good. And so actually the suicidality for him in his situation was help keeping him safe, that he had a way out and he knew that there was a way out, in order that, and that way out enabled him to not do it, enabled him to live today, because he knew that he had some control over and how long he was going to be around. And yeah, because being around for him at that point, and I've been for a while, was a very difficult thing to be. It's a long answer to a short question.
That's okay. And like I said, I've been seeing you for 4 years now, and you know, I have this diagnosis of bipolar disorder, for which I take medication. I see a private psychiatrist, and I see you privately. And what I found in my experience is that it's not either medication or talking therapy. For me, it's both. And although I've still had episodes of being unwell, they are shorter and not so extreme. And I now have more stability, so that when I do go into an episode, it's kind of awful for me, because you feel like you've never been like this before, and this is the end. But I suppose for my husband, who's my carer, it's and you've kind of seen this before, and you hold the memory that I've got better whilst I'm going through the awfulness of, I've never been like this before, and this is the worst I've ever felt, and I'm going to die. And so that's been really useful for me.
Yeah. And if you look at, and it fits with a lot of epidemiological research, that in GP services, if people have the same GP for a number of years, a consistent GP, the outcomes for all conditions are significantly better. There's something about knowing people in healthcare interactions and building that over time, even if it's intermittent. You might see them once a year, every 6 months, or whatever it is, and we've met each other at different frequencies, haven't we, across time, and had breaks and what have you. But well, as you said, there's something about the memory, but there's also something about what I would hope to be, I suppose, is a secure base, is somebody who's going to consistently hold you in mind, have a consistent approach to you and how you are, and a consistent regard for you, of course, that you can rely on. You know what you're going to get. I do like the maxim that is no surprises. Do you know what I mean? If there are surprises, at some level, we're getting it wrong. And so, yes, and if there are no surprises, if you know who I am and what I do and how I do it, then you will use me in a way that's most helpful for you. So sometimes I will say to that, go on, sorry, yes, go on.
I recall early on, because I got bipolar disorder, and depression, and before it was diagnosed, I've had blocks of CBT and other, I've got no idea what they were called, interventions. And I remember when I first met you, and I said, Andrew, are you sure you're a clinical psychologist? And you said, why? And I said, well, you haven't asked me to fill in a questionnaire. Because my experience with NHS interventions is at the start of every session, whether you're sitting in the waiting room or you go in to see the therapist, is that you have to fill in a questionnaire. And that because I'm so old and jaded through that system, it was just really refreshing that you were prepared to take the time. You may well have asked the questions that were on the questionnaire, but you didn't ask me to fill in the bit of paper, which was a blessing.
Yeah, well, Well, my experience of questionnaires as a patient and as a healthcare professional over a long period of time is the vast majority of people don't want to do them. And if people don't want to do something, then they're not giving informed consent, and actually that's against the law. I'm sorry, you know, when you say I have to fill in the questionnaire, well, I'll be very clear. You don't have to fill in the questionnaire, because I can't force you to do anything. I shouldn't be forcing you to do anything unless it's sanctioned under the Mental Health Act. And filling in questionnaires is not sanctioned under the Mental Health Act, I'm afraid. So there's a real problematic culture of paternalism and of forgetting the person's feelings and rights and what have you, and that kind of gets in the way. And I have to say, it's a crying shame. To me, it's a monumental waste of time. Not that there's anything wrong with questionnaires, and some people like them, some people enjoy doing them, find them illuminative and brilliant, and some people don't. And my experience is most people don't. And so we start where the person is, and I don't know what the function of the questionnaire is to get information. There's lots of ways to get information, isn't there? And there's lots of ways to, but there's also, health services are very good at collecting information. In my experience, they're not very good at doing anything with it or doing anything useful with it, apart from collecting it. They get huge amounts of data, but don't really do a lot with it and don't use it usefully. And kind of, I was just trying to think the information. Well, yeah, I suppose my primary thing in the information is, again, what I would start a session with, what would you like to do with the time? That's the most important thing for me. You will always have more information about you than I ever have about you or about your life. I want to instigate within you a sense of autonomy and control and confidence that I'm here as a resource for you to use, and you can direct me as you think is most helpful. You are the customer. I said to someone on, I can't remember what I said. I said, things can't be considered a service if they can be withdrawn. That's not a service. If it can't be chosen, if we can't choose a different one, do you know what I mean? That's not a service. That's an administrative body. A service is something that provides something to us that we want and we choose to have or don't choose to have, and reflects what we want in what it provides. That's the definition of a service. But that's not how far too many services work. Sorry, they're not services. Far too many state organizations provide what they provide.
Yes, and it's what I found is that if you don't accept whatever they think you need now, you will never get access to it again. So it's kind of like, you know, going into a garage and saying, I need new tires, and them saying, well, you know, you have to take this.
We don't think you need new tires.
Exactly.
We've changed your exhaust. We haven't asked you, but we've changed your exhaust, and it's 300 quid. And if you don't like the exhaust, you're never coming back to the garage. Sorry, I like the analogy.
if you don't like the exhaust, we will talk at you forever until you accept that it is a nice.
We'll convince you that you do need a new exhaust. Yes.
Yeah.
Right.
Isn't it lovely that we've given you this?
The new exhaust off. We'll put the old one back on, and then you can go on a waiting list for a new exhaust. Yes. It sounds bizarre, and of course it is bizarre, isn't it?
It is.
It's worst. At its worst, healthcare replicates the very problematic patterns of relationships that often people with mental health problems have had in their lives and come for help with. Whether that's through trauma, whether that's through family difficulty, whether that's through the difficulty, the stress itself of just having a mental illness, and how that affects our ability to work, our ability to relate to people, our ability to be a husband, a wife, a mother, a father, all of these things. There's a lovely phrase, and it applies to other public services, of course. Yes, when the teachers forget who the children are, we're in trouble. And when the healthcare professionals forget who the patient is, they're in trouble. And that's the danger. That's the danger of big organizations. That's the danger of believing. There's a word here that imagining that you know better than the patient. Sorry to be straightforward. And because 99.99999% of the time you don't. Only in the very small instances of when people are incredibly acutely unwell do you then, and again, this is the Mental Health Act. There's a whole legal framework for that. But even then, in the Mental Health Act, you must consult with the person. You must seek the opinions of them and their loved ones, people who know them when they're well. Do you know what I mean? All those decisions that the person doesn't make should be massively informed by all the codes of conduct, by all the things we're talking about anyway. So it's almost like obliterates it. Does it make sense?
Yeah, it does. I think that, one of the things that certainly people I've spoken to who have been detained under the Mental Health Act is that you actually get better treatment and more control, and you're asked better questions than if you go voluntary. And so actually having the legal part is a protection for you.
Yes, and actually go on, sorry.
I was going to say the other thing is what I've heard in my past is you can't have more than one therapy at a time. And I wanted to speak to you about.
I smile and laugh, don't I? Yes, which I always say to the professionals who've told me this is, well, if we're in child and families, are people allowed a mum and dad? Are children allowed more than one person who professionally cares for them? Do you know what I mean? A CMHT is a team of people who care for a patient, all of whom have an explicit part of their code of conduct that they have therapeutic contact with the patient. So the idea that you couldn't have two people trying to help you therapeutically, psychologically at the same time, it makes no sense to me, because it goes against the whole model of teamwork, CMHT teamwork, forensic teamwork. the whole model of a family. We know the outcomes in families where there's two actively involved parents or guardians or other people, the better the outcome. So it flies in the face of all the epidemiological and practice evidence that we've got. So to me, it then comes back to this, well, what's in the best interests of the practitioner rather than what's in the best interests of the patient? And yeah, it's one of those situations in my experience where people have forgotten who the patient is, and that the patient needs to decide. The patient is the arbiter, and the patient knows what their best interest is 99.999 again % of the time, and it's up to them. Does that make sense? If someone's got capacity to consent to one intervention, they've got capacity to consent to two.
Yes.
They're the arbiter. Once you recognise that person is the arbiter, and has to be the arbiter by law and by ethics, then telling people what treatment they should have is unethical.
Yes, right. Final question, which you may not be able to answer in the last.
I will try.
7 minutes. This isn't a question from me, but I'm interested in it.
Sure.
So PTSD, CPTSD, what are they? How do they differ? How are they similar? You know, all these arbitrary labels and divisions and all that stuff.
Yeah. Well, I can certainly try. I talked about PTSD first. So I did my doctoral research on trauma. So I have looked into it in some depth. I'm probably better equipped than most, I suppose, people who haven't done a research in that respect. So PTSD to me, well, first of all, these two things are diagnoses, aren't they? They're the first things to say. And all diagnoses are categories. So right. So what does that mean? So that means it's a big broad tent, and I'm going to change my metaphor. In the diagnoses, the person will often ask a questionnaire or a structured clinical interview or an unstructured clinical interview to identify whether a person has particular symptoms that fit with the diagnosis. And if you have enough symptoms that fit with the diagnosis, you'll be given the diagnosis. Again, problematically, sometimes if you don't want the diagnosis, it really should be your choice as an adult with capacity, whether you receive a diagnosis or not. Receiving a diagnosis is a healthcare intervention that we should consent to or not consent to, as we wish. We know that having diagnoses comes with significant social and cultural implications, and so again, I think it's unethical for any healthcare professional to provide a diagnosis without the consent of the patient. Next, so PTSD. So PTSD has 3 core symptoms, which are hyperarousal, avoidance, and intrusive phenomena. These are the difference. I'm aware at the time. The primary difference between psychiatry and psychology is that most psychologists think about continuums, because they would think about phenomena in terms of continuum. So in terms of a traumatic response, they would think people who have at one end of the continuum, I'm just drawing it out for myself to help me think about it, as a no traumatic response, i.e. we experience something and we understand it well enough, it fits well enough within our understanding of the world, our reaction to it is not extreme, it makes sense to us, we are not, the word be shocked or disturbed by it, we accumulate the knowledge and move on. So we can think these things will happen every day. Every day you go to the shops, Fiona, there's a different set of people in the shops. There's a different person normally behind the counter. You will buy a different selection of goods, okay? But because you've gone to the shops lots of times, the fact there's slightly different people there, the fact that you may have a slightly different collection of goods, you may take a slightly different route home, isn't traumatic to you because you know it well enough. There's not a massive difference in that you normally appreciate in every shop.
Yeah.
Does that make sense? So that would be a non-traumatic experience. But the other end is hugely traumatic experiences, and where PTSD came from, obviously from shell shock and Wilfred Owen and the First World War, is most of the time it started to be codified, started to be described as a phenomena. is people going into incredibly unusual situations than they're used to. So we can think about, well, I'm sure people in 1914 went to the shops, but you then go into, well, then you go into Flanders Field, then you go into a mechanized murder factory where people are getting blown to pieces everywhere in front of you. For 99.99999% of people, that was incredibly different, incredibly novel, incredibly unusual for them compared to their experiences before. So you can contrast that to you going to the shops, very ordinary, very everyday, non-traumatic. All of a sudden you go in somewhere that's entirely different in what's happening, how it's happening. And we can imagine that actually, hang on, I'm no doubt there were lots of psychologists who went to the front in the First World War. I check myself. Right, I'm now in a trench. I've got a gun. I've got a gas mask, and I'm going to go over the top and I'm going to fire this gun at those people over there, and I'm going to try and kill them with this gun. And while I'm running towards that, they're going to be shooting at me, trying to blow me up. And the people I know and care about are also going to be blown to pieces and die and never come back. And we can immediately say how different that is from my ordinary life, from everybody's ordinary life. And so the idea of trauma is that we experience something that is very, very different to what we've had before. Does that make sense? It's just a really simple idea of, because I think it's really important to get in our heads what actually people think is trauma, because that underpins it all. That underpins it all, because the symptoms I talked about are responses to that kind of event. But the important thing is, well, let's understand, what would that kind of event be?
Right.
For anybody. So, go on.
So in terms of
we've got a couple of minutes. Go on.
And saying, okay, I think I react like X in situation Y, and you say, oh, well, those symptoms of X, hyperarousal, and those three
avoidance and intrusive phenomena,
could that be post-traumatic stress? The question that I was asked from somebody on social media was that they feel that their experiences aren't traumatic enough to get help with, because somebody has said, oh, well, that's on that continuum, it's
yes, but I would,
they've internalized that. And so they're now thinking, oh, well, I'm just making a big deal of it. I'm just a drama person.
Okay. And that makes no sense to me as a psychologist. It makes sense to me in terms of the categories about PTSD. So they will say, well, it has to be a life-threatening event or a near life-threatening event. Well, okay, that's a categorization for PTSD. It is not a descriptor of whether someone is traumatized or not. That's an entirely different thing. And sorry to be straightforward, we can be traumatized by anything.
Yes.
Anything that is unusual and novel and sudden and out with our compass can traumatize us. So the idea that there is a categorical, well, that's to do with the diagnosis, whether you get a diagnosis or not. There's nothing to do. As I understand trauma and I understand psychological reactions to trauma, that's nothing to do with it. But I'm aware that the time and we do need to stop.
So Andrew, thank you. We're hoping to work together and produce a series of these Ask a Clinical Psychologist. So I've got no idea what the next one will be about, but I'm sure I'll think of something. So thank you for your time, and this will be uploaded onto your website.
Brilliant. Thank you, Fiona. Lovely to see you this morning. So, how was that?